going to go ahead and get us started, and others can hop in as they become available. We are a flexible bunch as crisis folks. So we'll go ahead and get things going. And so our starting point, and just to kind of orient us, we have about an hour and 15 minutes together today. We'll start by having the panelists introduce themselves. I have some questions for them that will help us better understand their services and how to best refer to them and all of those good things. And then we're also hoping you'll put questions in the chat. You can put questions in the chat for specific individuals, or you can put questions in the chat for the whole group. I'll be pulling the questions off as the panel goes on. And once we have our couple basic questions answered, we'll make sure that we get to the audience questions as well. And if you're feeling shy, you can always message me directly. So with that, I'm going to ask people to just please take a couple minutes to introduce yourself and give a broad overview of the program you're representing. And just for the sake of knowing how to make it get going, we'll go in alphabetical order. So we'll start with Allison, then Clara, then Elliot, then Captain Garcia, and then Karen. So Allison, do you mind introducing yourself first?
Sure, thank you. My name is Alice Nakayama. I am the mental health program supervisor for crisis services for the city of Berkeley and Berkeley Mental Health. We have, within our crisis program, we have our mobile crisis team, which I'll talk more about, and then also our CAT team, CAT, not to differentiate from CAT double T with the county, which is our intake team and essentially access and access program for Berkeley Mental Health. Nice to meet everyone.
Thanks, Allison. I think that's the start of us knowing there's a lot of acronyms coming our way today. So I'll pass it to Clara.
Thank you so much. Welcome, everybody. My name is Clara Geronimo. I am the clinical program manager for CAT with a double T. It stands for Community Assessment and Transportation Team. We work in the entirety of Alameda County with the exception of the city of Berkeley and Alameda. And it's nice to meet you all.
Hey everyone, sorry, a little flustered. A friend of mine from high school is on this call too. What's up, Christina? Really good to be here today. My name is Elliot Jones. I'm the program manager for the excuse me, for the Oakland Fire Department's Mobile Assistance Community Responders of Oakland, or better known as the MACRO program. We've been in service for about 2.5 years. Happy to share about our experiences and what we're finding out in Oakland. Thank you for having me.
I think it's Captain Garcia, Karen, and then Thema.
Hello, everyone. My name is Kyle Garcia. I'm the EMS captain for the Alameda Fire Department. I oversee our EMS division and specifically our care team, which is it's a team for community members who are experiencing periods of mental health crisis or behavioral health crisis. And we work with Karen from AFS.
Hi, everyone. I'm Karen Zaltzer. I'm the Division Director of Crisis Services at Alameda Family Services, and we partner with the Alameda Fire Department, providing licensed on-call clinicians 24 hours for consultation, follow-up case management, and an internship program providing therapy to people who have had a recent mental health crisis in the city of Alameda.
Great, and Thema, we're just doing an introduction.
Yes, I definitely heard that. My name is Tama Page. I am a behavioral health crisis intervention specialist supervisor with Alameda County Behavioral Health Department. And so Alameda County has multiple iterations of crisis teams that respond throughout the county. I don't know if all of those teams are represented by me, but just in case they are, within our system of care, we have co-responding teams. So those are mobile evaluation teams or MET teams. Co-responding teams come out of Oakland and Hayward. So there's a clinician that's sitting in a police vehicle with an officer, and they go out together and respond in the community. And then we have mobile crisis teams that are county teams serving specific areas. And that's 2 clinicians who are out in the field completing those assessments and sometimes collaborating with law enforcement when needed on that. And then finally, there's the CAT team, which is, I always get stumped on CATT for the county CAT team. But they also have like a collaboration with law enforcement, and it's a county contracted team, but still a county team. So that falls under our umbrella.
Thank you so much. And that kind of actually works us into the first question. So I'm going to have you speak to the first question first. And this is the most common question we get on our crisis lines, which is the extent to which each mobile crisis team collaborates with law enforcement. So I think both about like whether that's part of your model, but also maybe under what circumstance, even if it's not part of your model, would you be tagging in law enforcement? If what happens, does a mobile response turn into a law enforcement response for your specific team? And I'll start with Tama and then go to the care team with Karen and Captain Garcia, and then kind of we'll continue to send it to everyone because I do want to hear from everyone on this. Again, this is the most common question we get.
Okay, and so just in explaining like the 3 different kinds of teams, there's one that's like embedded literally in the vehicle with the police officer responding. And so if somebody is receiving a call that team is responding to, you'll see both coming out together and doing the assessment. And those teams are typically dispatched by law enforcement and also can have dispatch coming in from, in terms of their assignment, coming in from our center as well. And with that, it's mostly like based on area as far as like who is responding, because those MET teams are strategically placed in serving specific areas. And then when we look at the other models where it's like the 2 clinician model mobile crisis team that goes out, they choose when they're going to enlist law enforcement support to respond with them. Sometimes they might get somewhere and then realize, oh, it might be beneficial for law enforcement to be here. Other times they may know that before they arrive, like if they know there's a dangerous situation or something that requires more expeditious response, immediate response, then, law enforcement would be enlisted to try to ensure that, the safety for the individual who's experiencing the crisis is preserved. And also for the clinicians who are there at the encounter as well. And then I believe that, I don't know if I should cover CAT for Alameda County or not. So I will leave that to
No, we'll
Kat.
have them speak directly about
Excellent.
the program.
And so for ours, there are times where we do respond and we don't involve law enforcement at all. And there are times where, law enforcement is always going to be with us, such as in those 2 teams, one coming out of Hayward and one coming out of Oakland.
Thank you. And between Karen and Captain Garcia, who would like to speak first?
I'll go first. So our interaction with the police department actually starts with dispatch, because our dispatching 911 calls go to police dispatch, and then when they do their EMD, they determine whether it's going to be like a 911 emergency call or if it's what's called a care team call. So if it's a care team call, they'll notify our dispatch, let the care team know that they have a call. The care team will then call the police department, and they will try to get the information for why they're being called out there, to try to get a little bit more information. When we originally started the program, the police department responded with the care team on every single call. And through the first few months, we realized that wasn't necessary on every call. So what we did was we changed our dispatch model to what are called APD priority and AFD priority. So like with an APD priority call, that would be a call where there was some sort of danger in the situation, whether it was a violent patient or someone who was making threats or there was potentially a weapon in the home or something like that, APD would respond, and they still will, and they will make sure that the scene is secure before the care team will go in there and begin contact with the client. If it's an AFD priority call, we will not have the police come out, and AFD, the care team will go out themselves and they will initiate the contact with the client. And what we found was in the instances where we don't need police presence, it's actually more beneficial just to have the care team there, because it allows for us to start those conversations to see what's going on without them kind of feeling like there's some sort of potential punitive measures or anything going on. And it allows them to kind of start that conversation to see how we can get them the services that they need.
Thank you. Appreciate you kind of
Yeah.
also walking us through how the team has evolved. Go ahead, Karen.
Yeah, I don't have much more to add to that. It has been, I think when we started, we weren't sure what to expect, what the care team was walking into, and having APD just to kind of make sure people were safe. But as Captain Garcia said, it felt like the majority of the phone calls absolutely did not need APD there, and having them on the scene, created a different feeling on the scene. So moved towards this model, which has, I think, been working extremely well, just to have the care team get a little bit of information about, kind of what they're walking into, what to prepare for, and then being on the scene without APD presence.
Thank you.
If the police, sorry, if APD does take the lead, sometimes their focus is really just securing the scene and making sure it's safe, and then they initiate the care team to take the lead at that point. So even if it starts with APD, it may not end with APD.
Yeah, I'm gonna pass it on to Clara, actually, because there's quite a few questions in the chat about CAT.
Thank you. So the CAT team, like I said, is Alameda County wide. We get dispatched through ACRAC via police referral. So the police on scene are responding, and they will determine that it's a mental health call, that they are not able to make a quick determination or green sheet the person or resolve it in their means. They will then call for a CAT response that will get dispatched through the 911 system. And one of the units that is up will then respond. At that point in time, our clinicians are able to cut PD, and I would say that happens for the majority of our calls. They're able to let PD go because the scene is safe, and we are doing a safety plan, or we're doing some other sort of resourcing for that client. If anything goes squirrely, which sometimes it does, and we can't help it, we are able to call PD back to the scene, but our clinicians are really well trained to be able to manage and mitigate most of these situations. The unique thing about CAT is that we also transport those clients. So even if a determination has been made that a hold is necessary, we can provide those clients agency and ask them, what hospital do you prefer? Where would you like to go? Is this an Amber House thing? Would you be safer if you're just with mom? And we're then able to provide that transport because we have the vehicles that allow us to do that. That's kind of CAT in a nutshell.
Appreciate it. Elliot, and then Allison.
No, thank you. Want to kind of reiterate what a lot of people have said. Garcia, thanks for kind of detailing how the 911 system works. So that is our first touch with PD. If a call comes through and they deem it appropriate for a macro response, they send it to fire, that'll send it to macro. I will tell you, my favorite thing, though, is when officers are on scene and they're like, this should be a macro call. And they call and request us directly, because then it's a quick handoff, a handshake, maybe a little exchange, and we can go. We had in the month of August 4 instances where we had to kick things back to PD, but that was mostly for a crisis response per the rules that Clara just outlined. And again, this is all very cordial. It's all very understanding. I think it was, in our first year, a little bit more uncertainty about what we're going to do. But now 2.5 years in, they almost expect us. So getting over that threshold to allow them to pass it off and really understanding that not everything is at crisis, so that we should be able to, we handle 96% or more of all of our calls we're able to handle and clear. And I think that's a really good, ratio for us. If we have to kick it back, it's for a very specific reason. And it just takes time to get law enforcement to understand you are here. You can count on it. I even think we would say with resources, when something isn't reliable, we don't use it as much. So when you get to that point where you are an asset to PD, you find that they call willingly and often.
So for our team, our mobile crisis team, we are a co-responder model. We have our 2 clinicians who are set up to respond individually to calls during the day, and all of those calls for services are generated by law enforcement. So the officer who's on scene will call us, will call the team to request mobile crisis, to do an evaluation, to help with de-escalation, whatever is the need in the moment. In the evening, those 2 clinicians then pair up to be able to respond to, again, with calls to law enforcement. There is some phone, I will say there is some phone work, so it's not, while the team is primarily in the field, and that's our main focus, we do and can take calls from community members wanting just to kind of talk through different options to get mental health resources and information and things like that too, and the team can do that as well. I would say the team can do some calls without law enforcement, but because most of the calls are generated by them, I would say the majority of our responses are with them.
Thank you. Elliot, are you going to tell us what macro stands for? There's someone in the chat who's asking.
Oh, it's tattooed on my forehead. Mobile Assistance Community Responders of Oakland. It's a mouthful, so I'll say it again slowly. Mobile Assistance Community Responders of Oakland. So much easier to just go by macro. And a little history on the name, because someone told it to me. It was supposed to kind of be a nod to MacArthur Boulevard, something that connects all of Oakland. So, that's all BE before Elliot, but I'm happy to have the history for y'all.
Appreciate it. And there's a question in the chat asking about the vehicles, and I really appreciate Stephanie Lewis, who's the division director for crisis services for the county. She's been fielding questions in the chat, so big thank you to Stephanie. And I am capturing some that we will come back to once kind of our more overview questions are done. So the next question is about scope in terms of who's an appropriate referral for your service, whether there are geographic boundaries, whether there are deal breakers of if blank, we won't go out. If you want to use a story to demonstrate it, that's cool. If not, just helping us understand who the appropriate referral is. And I'm going to start with macro this time because they do have a kind of more finite scope, and then head to Berkeley and then Alameda and then to the countywide teams.
Finite. I thought it was more broad, but okay. One thing's the geographic boundaries.
No offense. No offense.
no, I'm totally offended. The geographic boundaries are Oakland. We respond through any address in Oakland, all over the city of Oakland. Even when we get to the porous area and the borderlands of Emeryville, Berkeley, we do respond up and down San Pablo. So even then it gets a little gray. I would say the ideal client and what we try to focus on is the low acuity quality of life calls for service. And that's so many of those. So when somebody is driving by and they see somebody sleeping on the ground and like, hey, this guy looks dead, that will go to a macro team, if all the man down stuff is done correctly, instead of having a fire unit or police officers come and check it out. We get a lot of the low-level behavioral concerns. We like to believe there's a lot we can do up to crisis. And then if something gets to that threshold, we contact Claire's team through PD. And that, I think, if we are handling as much of the low acuity calls as we can handle, those quality of life calls, that they don't get to Clara. They don't get to the firefighters or the cops. We have this charge to keep things cool, not necessarily move you or remove you, but to try to come to an understanding and build up a rapport over time so that we can make it an appropriate service connection. We're able to make a connection to services about a third of the time. And I'll be honest, if we were doing it at any more of a higher rate, we probably would not be able to make the appropriate connections. So people have to be ready. It is totally voluntary. We don't force, we may nudge, but we don't force you to do anything. And we have found that has been pretty effective. It does require constant level setting and resetting, not only with the public, but with our team, because we don't want to get the trap into being caseworkers. even though we may see somebody weekly, daily in some instances for months on end, we are there just to address their basic needs, break through some of the trauma they have with contacting services, and hopefully make an appropriate connection.
Thank you. Allison?
Yeah. Berkeley Mobile Crisis responds to any call for crisis services within the city limits of Berkeley. That does also include the UC campus and campus properties located within the city boundaries as well. I will put a shout out to my colleagues over at UC. They have a campus mobile crisis response team that's been in operation for the past couple of years, but they only respond to UC Berkeley students. We will respond to anybody who's having a crisis on campus. That can include students, but it's often community members, sometimes clients of our clinic or other mental health clinics as well. So we will respond anywhere in that way. In terms of ideal client-wise, I would say majority of our work, I would say the bread and butter is doing 5150 evaluations and safety planning around that. Folks can call, on themselves, saying that they're not in a good space. Oftentimes family or friends will call. We also get kind of the quality of life calls for service in terms of, hey, we see somebody down, can you guys respond? So those calls we will direct through 911 for evaluation around physical health needs first. And then if the fire department or the paramedics on scene or the officer feels that they need to have more mental health support, then they will call us out and we can respond to those as well.
Thank you, and thanks for also clarifying how it works with the UC as well. Karen, do you want to tell us about how it works in Alameda?
Sure. So people can call the care team for themselves, family members, community members, and different organizations when somebody is experiencing really any kind of a mental health challenge. A lot of our clients express suicide ideation, and we are doing an assessment of, level of need, including up to 5150s or 5585s. We're also working with people who with de-escalation, safety planning, and alternative transports. So places like Amber House Respite, Malabar House for Youth, alternative transports, sometimes helping people get their medication by transporting them to Walgreens. So really whatever the needs are. We do have clients that are adults. We have clients, our youth. I think our youngest has been 5. I think our oldest was like around 97. We take calls for people who may be having acute crises of psychosis, delusions, and clients that are experiencing grave disability, and we're doing grave disability assessments as well. So a typical client could be really anything. And our goal is to try to decrease unnecessary hospitalization. So the care team will spend a lot of time trying to de-escalate, safety plan, think about alternative transports, or bringing in family members and support to then make that referral for the next day getting case management support. But those who are really at risk to themselves or others or gravely disabled, we will, do that transport or encourage voluntary transport for further assessment.
Thank you. I appreciate that. I'm going to go to Clara for the CAT team, and I'm trying to save the questions, but there's a question about CAT being or not being 24/7 that feels relevant in this moment. So I'll have you address that as well.
So we are inching our way to 24/7. Sunday through Wednesday, we are 24/7. And then our back half person will be starting soon, which I'm very excited about. Kind of echoing what Kara and Elliot said. And Elliot, we love your macro referrals. Please keep them coming. We respond to any sort of mental health crisis that occurs in Alameda County, whether it's in the general community, at a school, at a particular establishment, and so on. We will respond to any sort of escalation in psychosis, suicide ideation, homicidal ideation. I think the things we kind of aren't necessarily appropriate for CAT, which I would assume might be similar in other teams, would be domestic violence issues. Those are inherently really dangerous calls we don't go out to. And the CAT team doesn't typically respond to active suicides. Our Pleasanton ARU team, which is a co-responding team through Bonita House, does respond to those, but not CAT. We do a lot of follow-up after the call, and we do try really hard to kind of divert those hospitalizations as much as we can. We do a lot of work with reconnecting folks back to their treatment team. So you will definitely get calls from our clinicians about, hey, we saw your person. This is where they are. Work with us and come get them. As well as just finding them and reconnecting them to some sort of services in the county. Yeah, and that's kind of what CAT does. I did see a question pop up in the transport about the kind of cars, and it's just a white SUV. It's unmarked. It does look like a little bit like a police car on the inside, but we have snacks, we have water. We try to de-escalate as much as we can to get folks transported to where they need to go.
Thanks, Clara. And Tama? Oh, could you unmute?
I saw the notice. Thank you. So like a lot of the other teams, we respond to anyone who's experiencing a mental health crisis throughout in our parameters, it's throughout the entire county. And so we're in the community, in their living situations. So it could be a home or it could be someplace where this person is staying that's unhoused to assess. And then similarly to some of the identifiers of what folks have already shared about, like who we're responding and seeing. So we may be seeing youth at their schools or in their homes. We may be seeing adults in their homes or out in the community who appear to be a danger to themselves or someone else, or experiencing some acute symptoms of a serious mental illness. And they need an in-person response. And so there's different things that we may do to try to support them in getting the least, I guess, invasive response. So like if there is a support system already there and available, so for youth, we may, engage the parents around transporting them to be able to get the support versus our team arranging for their transportation and all of those things. So just to not be, too repetitive, but there are also places that we wouldn't go. Like, so for example, if somebody's inpatient in a hospital, we're not going to do that, right? Probably none of these teams are going to go and assess within any hospital or psych emergency department, those kinds of things. But we will, find ourselves in other settings. And there are other kinds of crises that happen in the community that sometimes, like the mention of domestic violence, I was thinking about, like, there's sometimes people who are working with youth that are in foster care, and that's come up recently, where we're not going to come in to respond to like foster care emergencies. However, there is another team that does help with placement stability, and that's the Family Urgent Response System, right? And so primarily it's focused around mental health crises that are occurring in the community. And trying to think if there's anything else to add that's important and different. So no criminal situations. If there's emergent medical needs that are going on, we're not the right source. You want to get medical care to those individuals. But if we uncover any of that kind of stuff while we're there, then we would support with trying to facilitate the medical care. Yeah.
Thank you. And there's been a number of questions about how do people get a hold of your various like agencies or programs. So I don't know if folks want to put that in the chat. Somebody's asking if calling 911 is the best option and 911 can kind of divert, or if you have direct numbers. Somebody was specifically asking about macro. Elliot, if you want to speak to that, if they know that, maybe we'll start with you. And then I will make the rounds because I do want to hear from everyone, like what's the best way for someone to get a hold of you?
So there are three primary ways to contact and request a macro response. I started to type it, but hit enter too fast. So I'll just tell you guys before I deal with that later. The first way, and what we will ask is that please do not call 911. People do call 911. It happens. It's okay. They're trained to send it over. But the best way to request a macro response is by either dialing the macro direct line, which is 510-44-macro, or 510-446-2276. Just rolls right off the tongue.
Yeah.
The second way, which I think we actually appreciate even more than the phone line has an auto attendant. It's designed to slow people down. It's not going to be emergent. You're going to listen to every word of the auto attendant before making your selection. So while some people get ratcheted up with that, it mostly cools people down. And some people decide, okay, I'm not calling. But the most effective way I would say is the email, macro@oaklandca.gov. This goes directly to our teams. It allows us to reach back out and do some immediate follow-up. If this is an ongoing challenge, it gives us a little bit of background that helps us share with other agencies or groups or as needed. Again, though, you open yourself up to well-intentioned individuals, asking and requesting help and services, which is fine. We don't want to deter anyone. But I think it's a great way to let people unload and to share whatever their issue is, and then giving us a chance to not activate any of the other services to respond. So 911 is an option, of course, but we would prefer if you dialed 510-44-macro or emailed us at macro@oaklandca.gov. And they all have their benefits, but for us, it's about slowing everything down. It's something that we're also working to practice on, but I'll throw all this in the chat as well.
Thanks, Elliot. And Ben put the macro email in the chat already and kind of provided people some guidance on how to email macro, like what to put in the subject and things like that. And so do you want to give us a sense of the response time? And then that way everyone else also, when you talk about, because there's been a couple questions about response times too, as everyone else is telling us the best way to get a hold of the team you work with, let us know what response times to expect.
So one thing I didn't realize, how many people are just on this thing. Congrats all of you for being here on a Friday. These questions are flooding in and it's a little tough to keep up. So similar to our if you were to dial 911, there is a language line available to dispatchers. A couple languages are spoken in the dispatch center, but they can always go out to get translation. Similar, if you email us, Google Translate, we'll do our best to kind of decipher that. We're working on enhancing that, just having more language capability, but it is a shortcoming. That was just the one that just popped up.
Response time is what we're.
There we go. The response time is usually pretty quick. We average about, I think last month over 5 teams in service per day, and we try to distribute them throughout the city. So while we're non-emergent vehicles, no lights and sirens, we do have a response time that ranges anywhere from 5 to 10 to 15 minutes at the most. Even if you have to come across town, if they're not on another call, they can get to most places within 15 minutes. Responding to the emails, if you send an email right now, well, depending on who the supervisor is, if they are not busy, they can respond sometimes within minutes. If even it's just to acknowledge email received, some of the ones where they're not asking for a response but are presenting a broader challenge, we don't just dive into those because they're a little more nuanced. But we do respond as quickly as possible, and other than the limits of traffic lights and things of that nature, I'd say anywhere between 5 to 15 minutes for your typical response.
That's great. I will pass it to Clara to talk about CAT. So we're talking how to get a hold of you, response time, and then let's put language capacity in there too, to address kind of the trifecta of access to resources.
So right now, the way CAT is dispatched is through PD. We are working on other methods of direct dispatch at the moment, but those have not come up yet. PD will request us through the 911 system. Our max response time is 30 minutes. Generally, we have teams that are placed in Oakland, San Leandro, Hayward, out in Fremont, and as well as Livermore. So we try to minimize that response time. So our max is about 30 minutes.
Great. And language capacity on the team?
We use a language line, and we do have a lot of Spanish-speaking EMTs and clinicians that can support, but that's kind of our limit. But we do offer a language line, and we use PD as well when necessary.
Great. Thanks, Clara. Tama, what about your teams?
Thank you. So language capacity, I was trying to think, what was it? So I was going to start with reviewing that. On our team, we do have bilingual staff. So we have Spanish, Vietnamese, and Cantonese, I believe. And then we also will utilize the language line to not overburden those who are bilingual. And then we also have staff who have basic ASL skills. And with regard to, I forgot the other piece of the question because I was like, oh, language, I hadn't thought about sharing about that.
Response time.
Response time. Response
Oh yeah, and how
time-
do we get you? Like, who do we call?
Gotcha. So how do you get us? I'm putting our phone number in the chat. And so that's a number that contacts the county teams directly, and you can call to reach us to request a team. Sometimes we get our calls from other places. So I think Stephanie previously mentioned in the chat directly from law enforcement. And then also because there's no wrong door within the county, like there may be somebody calling in to access, and then that is, coming over to us as well because it's been deemed a crisis. And they have a different phone number. And so in regards to response time, we try to be responsive, like as soon as we're getting, so we may get there really quickly. And then there's also a lot of high need in certain areas. So the response time may be longer. Our goal is to be anywhere within the, city area within, city areas within an hour. But often it isn't a full hour that people are waiting for a response. So it could be, oh, you're there in 5 minutes, or it could be a very busy time and it is taking longer to get there.
Great, thank you. Allison, do you want to speak to Berkeley? How do we get a hold of you? Language capacity on the team?
Yeah, absolutely. So few ways to get a hold of us. So for any kind of urgent needs, like a 5150 evaluation, if there's any kind of concerns about safety, would recommend folks use 911. In the chat, I'll put in all this information too, but Berkeley Police Department's dispatch comm center has a option for calling 911 via cell phone. So this is by dialing this number directly, 981-5911, that will go directly to the Berkeley Comm Center 911, so you don't have to go through CHP or any other kind of things for delays. If you want a welfare check or kind of general concerns about quality of life issues, like things like that, then the non-emergency number, which I'll also put in there too. Just a pro tip, the comm center has gone to a phone tree under their non-emergency line. So I would say push option 2. It may sound weird when they give you the option on there, but press that and then you can speak directly to the dispatcher. For general mental health questions or consultations or concerns, if you're unsure if somebody needs a mental health evaluation or you're unsure about kind of what resources might be available for someone in a crisis situation, you can call the mobile crisis team directly and leave a message because we're often out in the field and we will call you back as soon as possible. For language capacity, we have the language line. And then as well as we have a staff person who speaks Cantonese, a full-time staff person who speaks Cantonese, and then a part-time staff person who speaks Hindi, I believe. So those are kind of what our options are, but I would say the majority of it would be going through the language line. And then was there anything else that I've left out?
What are the hours for your team?
Sure. Yeah. So we're operating 5 days a week we have 10-hour shifts. So we are open every day except for Tuesdays and Saturdays. So Sunday, Monday, Wednesday, Thursday, Friday from 11:30 a.m. to 10 p.m.
Great. And did you say the response time?
Yeah, response time, I would say from the time the officer calls is if we're not on a different call, another call, then we can respond within, I would say you can pretty much get anywhere within Berkeley within 15 to 20 minutes. Up in the hills, it does take a little bit longer because it's a little wonkier to get up there, but that's probably a good estimate, and
Sure.
definitely less than that.
Great, thanks, Allison. I'll pass it to Karen, or Captain Garcia, you guys can pick who can speak to response time and who wants to speak to the team's language capacity.
All right, so I'll start, Karen. I'll start first. I see a lot of questions about hours of operation. So the Alameda Fire Department care team is 24 hours a day, 7 days a week. It's staffed with, paramedic and an EMT. So that's available 24/7. Doesn't matter if it's holiday or anything like that. For response times, it depends on, really the response time is once the person calls, there's two ways they can reach. They can call 911 or they can call our Alameda Police Department non-emergency dispatch line, which is 510-337-8340. And I can put that in the chat. So once that number is called and they determine it's a care team call, they immediately get toned out at the station if they're not on another call with another client. So the response time is almost immediate. However, the variables in there are as they're calling APD dispatch to try to figure out the situation, what's going on, or sometimes the clients will just maybe just want the care team to call them and maybe not drive out there. So that can affect the response time. But it really is just a matter of once the call comes into the station, they can respond out to it. And then I think that was it, right? And then Karen can handle the language line portion. Was there anything else that we missed there? Okay, thank you.
Okay. Our language capacity varies on a daily basis because the team that goes out is one paramedic and one EMT, and every paramedic and EMT at the fire department go through this training and spend time on the mobile crisis. But we use the language line, and the on-call clinicians can be contacted, and we can put get the language line involved and have it on speaker to support the care team in the field with the client.
Thank you. And thank you, Macro, for putting your hours in the chat. We've already covered Kat's hours, which is 24/7, half the week, and they're trying to make the whole team 24/7 by November. So close. They're hiring. As you can imagine, staffing these teams is tremendously challenging, y'all. And Tama, what are the hours for you all? The question came up after we already spoke.
Like trying to maneuver this mute button on the other side of my
No,
screen. Generally speaking, between 8 and 4.
So I'm going to shift us to kind of, I think this is building on the practicality, which is what should people be prepared to share when they call? So I know, like, depending on if I was calling for a spouse, the amount of information I have or could potentially have is very different than if I was calling for a neighbor or if I was calling for someone I've never met. So it would be helpful, I think, for everyone to understand, like, what are the baseline information that we should be able to provide if we are calling, hoping for a mobile crisis, kind of using that term broadly, response. And I'll start with the care team, then Berkeley, then CAT, then Macro, then County. So Karen and Captain Garcia, who wants to take the
I'm happy to. So when you call the non-emergency line or 911, dispatch has a set series of questions that they're going to ask you. So it's really easy to be guided through this process as opposed to, I think people are often overwhelmed or flooded or nervous. So you're just going to be walked through a series of questions. They're going to ask your name and contact information, where this is happening or where the dispatch should send people to. They're going to ask what's happening on the scene briefly. They're going to ask for identifiers for the person, if you know their name, age, appearance for identifying purposes when they get to the scene. And they are going to ask if it seems like there is a weapon on the scene or any violence happening. And that's also just for, kind of triage of who's taking the lead on the case, and also just providing information for the care team. And so those are just the general dispatch questions, and they're really good at guiding the process. And it's a pretty fast process, actually, to give the information and then have that dispatched. And as Captain Garcia said, it's a pretty rapid dispatch from that information till the time that they get on the scene.
Thank you. I'm going to tack a question on here because it seems relevant. Is there anything different if the individual is a minor?
No, it's the same for the care team. It's the same process for dispatch as well. And sometimes it's AUSD, Alameda Unified School District calling, and sometimes it's family members calling for a minor. And it's really the same process, just understanding what's happening at the scene and who is the intended client, and then how to differentiate from the triage of who's taking the lead on the scene.
Is like parental consent required in order to receive the service?
It actually isn't. And sometimes, for example, going to the schools, sometimes the assessment is done at the school without a parent present, so that it doesn't inhibit the process of asking the questions and speaking with school providers who may have already done an assessment, which triggered the call to the care team. We certainly contact parents and let them know what's happening. If it's really more of a de-escalation safety planning situation, we really encourage them to come on scene and do the safety plan as part of that together, because they're going to be often going home and kind of assessing if the parents have the capacity to support that youth with a safety plan. And parents can actually ask that if a youth is meeting criteria and is being placed on a hold, the parents can say no. But it doesn't impact the fact that we have this legal obligation now to get them to the hospital. And so they can follow behind, meet us at the hospital. But for the paramedics, once they meet that criteria and if a hold is placed, they really have to be brought to the hospital for safety purposes.
That's really helpful. Thanks, Karen. Allison, on behalf of the Berkeley team, and the reason I keep naming what entity everyone's from is just to orient everyone. So kind of what should we be saying when we call? What information do we need? And also, is anything different if it's a minor?
Sure. So I will say, yeah, again, because the majority of our calls are coming through, are being triaged through the Berkeley dispatch, I would say all the same things that Karen said around that. Dispatchers will ask their set of questions, all of that kind of good stuff, and that will get communicated to mobile crisis. I would say if folks are wanting just to call to consult regarding a situation, oftentimes the team will get phone calls from family members or friends or roommates or whomever and say, hey, person that one identifies the client, they're not doing well. They have mental health issues. Can you come out right now? And so the questions that mobile crisis will ask will be around, do you know of any mental health issues that they're dealing with? Are there any current stressors? Are they connected to service provider? Are they taking medications? Are they been prescribed medications? So they'll go through all this, and specifically the one around, what's changed right now? What is different now than it was yesterday or a couple days before, a month ago, just to try to get some background and some history prior to getting on scene. And I would say also too, again, as much as you can provide, certainly, I know those service providers who are on the call, your clients the best, right? So if you're calling because you're concerned, provide all of that information, because that can help our team make determinations around service and care. I would also recommend folks to complete the AB 1434 form too. That can be provided to an officer, can be provided to us, so we can take in and out all the historical information and then provide that to the hospital staff if it is determined that a person is going to be involuntarily hospitalized. We do serve minors as well, and so yes, same process as Karen talked about. We will try to involve the parents or the legal guardian as much as possible in the process. If they can't get a hold of them, they'll still have to make that determination regardless. And yes, we'd always like parents to be on board with kind of safety planning if they can't or won't or are unable to do so for whatever reason, if the determination is made, folks, the minor will still go on the 5585 hold.
Thanks, Allison. You mentioned a form. Can you say a little bit more? I don't know if I know it.
Yeah, the AB, when I want to say AB 1434 form, is it AB 1424? I can't remember. It's the Alameda County, every county in California has the form that allows for family members or other interested parties to provide information to folks who are doing evaluations. So in our jurisdiction, it's us as mobile crisis and the police. They can accept that as well. I would assume other agencies who have mobile response and crisis response teams can also accept those as well. So the families, friends, interested parties, service providers can provide all that historical information about someone's mental health issues, kind of what's going on for them right now, what's different, what's changed, any of that kind of good stuff that can be useful in us making the determination if somebody does need to go to the hospital, and if that information is relevant. The hospital, if it is determined that the person is going to be going on a hold, involuntary hold, then that information will get transported with the person and the 5150 green sheet to the hospital, and the hospital must accept that as well. So I will say that I believe that, if I get this correct, the law does require us to accept that information, but in our determination, we still have to go through if is this relevant to what's going on right now.
Of course. And thank you. One of my colleagues put the link to the form in the chat, which is always helpful. And someone else is asking, can people fill it out for themselves? And yes, it doesn't have to be someone else. In many of the tone of our conversations, often assuming someone else is calling, because many people here are in a helper role, but all of this information also applies if someone's contacting any of these helping organizations for themselves. Thanks, Allison. Elliot, for macro.
Well, I know a couple people asked about youth serving stuff, and while we do not typically respond to youth, we do occasionally get calls that are focused on youth. We, in a perfect world, would love to hand that off to the appropriate agency, but Johnny on the spot sometimes, and you have to work through it. We've had a couple successful connections in bringing in the family. Again, not everything is crisis. So understanding that this does not require an escalation. We've had a couple parents call us and, my son won't talk to me. And if individuals are willing to come out and meet us outside and in the street, we can engage, but macro does not go into personal dwellings or private homes. And there's a variety of reasons, but majority of these instances don't require that. And if somebody has enough sense to leave their room and, what was it the one time? Older child living at home arguing with their parent is essentially the mix. And I know that in the past, I've talked to people, and yes, they usually can rise up to crisis, but it got to us. They came outside, we talked, and we came to a pretty good understanding. He was going to listen to music and put on headphones and not get into it. Great. Nobody needed to be called. But youth are a persistent challenge. I would say, and sorry to harp on this so much, through the libraries, we occasionally get youth that are on the fringe. And it is so tough to be there and be ready and to build up trust with youth, whether they're, whatever's going on. So that's one that we're looking to be able to address further in the future, even though we aren't fully equipped now. We do our best. And what was the other part of the question? I'm sorry.
If we should have any specific information that we have ready, or what are questions that you might be asking if I call or email asking for support? Basically, what should someone know when they call for help?
Yeah, I think the one thing to stress for us is they do not have weapons and they're not actively being violent to themselves, others, or breaking any obvious laws. I get a bunch of the email doctor recommendations from people like so-and-so's here and needs to be taken care of. With all due respect to them, they are not clinicians. They cannot make that determination. And what we do know is that people will say stuff to folks in the street that are not authority figures. And then when we get on scene, it's a totally different story. So I may tell Karen, oh yeah, I need help. I'm ready to go. Whoever's here can help me. And then the team shows up with that knowledge. And it's like, I never said that, I'm not going anywhere. and we're already now on the back foot. So I would think the most important thing to stress is anything on current behavior. They do not have a weapon. They're not being violent. That's the most appropriate thing. If you could give us a little description of what they're wearing or their condition, missing clothing, highly soiled clothing, that could give us a chance to gather some stuff that we can, hey, maybe you want to change into this later. We can have that kind of carrot. And then I think finally, don't embellish or exaggerate. Not saying anybody on here does, but keep it 100, keep it real. No need to put extras on it. The moment you start adding something because you think you're going to get a faster response, you're going to get no response. And I remember getting a call. I say this example all the time. I'm just going to say it again. It was in West Oakland. It was a call. This is how the call came in. We have 3 guys with automatic weapons masturbating in the street. Now, I don't know how you juggle all that, no pun intended, but it just seems a little fantastical. And so they asked, would you guys take a shot at it? I said, yeah, well, I was riding with the team. This was really early on. And I said, yeah, we'll check it out. There's 3 guys smoking some dope on the corner. We approached them. Hey, we got this call, told them about the call. And one of the guys says, yeah, that's us. Now, after a brief but awkward pause, he explained further, we weren't doing all that, but we know who's calling about us and we're getting out of here. So I was like, okay, you understood. Automatic weapons was the trigger that usually gets people there. The other act, I don't know why they felt the need to add it. But it was something that really taught us early. We have to work with the public, like tell us the truth. And even another example, we had a producer of one of the local news was upset because her call wasn't routed to macro, and Garcia can speak to this. The call was for somebody laying down on their stomach, non-responsive. And that's a man down. Anything could be happening. You could be stabbed with the death note on, all sorts of stuff. And you need the police to check that out. Because she was a producer and she was irate, we sent a team over. The individual's now on his back. Totally different set of circumstances. The team walks up and engages, and the first thing he says is, I have a right to F and B here. Yeah, you do, bro. But if you don't mind sitting up, drinking this water and getting in the shade over there, I can promise no one else is going to bother you. So language is so important. And if we are dishonest with our language, we don't try to put extras on it. We don't get frustrated in understanding that our communication, and there's a reason why that guy face down, it could be something bigger. And in emergency services, in first response, we have to think about that first. And, over time that may change, but for now, we have to respect that. So I think those are the things that we need to know most of all. And just asking the public and everybody, be totally clear with what you're asking. And that's the best way to get it to the right team.
Thank you. I really appreciate the examples, both because they're funny, but also because they bring it to life of in crisis work, as Elliot has repeated, not everyone is in crisis. So trying to assess where things are at right now, what is the degree of response needed, is the number one tool anyone who works in the field of crisis has available to them, especially considering that resources are also limited, right? We don't have infinite number of teams here, even though, yes, we have a number of colleagues here, but we have a big county. And we want to make sure the right person is showing up on scene to support our community members. Tema, do you want to tell us a bit about kind of what should we be saying when we call in terms of information, and also around serving youth? Those are kind of the twofer that we're handling.
So what information do we need? We want to know why you're calling, like who's in crisis, the caller's information, if it's not the same person, right? The person in crisis is different from the person who is calling, how to contact you, where that person in crisis is, where the caller is if they're not together, if there's any imminent danger that we need to be aware of, because we might need to redirect the call, any medical emergencies or weapons going on, any history, like psychiatric history, history of violence, and then also if there's pets or any kind of like dangerous environmental circumstances we should be aware of. We want to know all that stuff if you have it. If you don't have all of those details, okay. We just at least need the details around like who is in crisis, what's happening. And then occasionally we may also need, and so it's helpful to have a description of the individual identifying information, just in the event that the caller doesn't actually know the person, but they're seeing something and someone's who's likely to be there, we could find them, but having information that helps us know who we're looking for is very helpful. And then for children, I'm sorry, I saw something pop up in the chat. I think you're asking like information for children still in addition, or no?
Yeah, like will you come out for youth or?
Oh, yeah.
Okay.
We see anyone who is
Okay.
experiencing a crisis in the county, period. So they don't even have to be like a resident of the county. They could be in the county and now their crisis is happening and someone needs to call and they can help us find them. Then we will respond and come out and meet with that individual in the community and conduct our evaluation.
Thank you. That's helpful. And Clara, I'm going to have you speak to the same thing. What information should we be providing? I know right now only the PD can dispatch CAT, but I think as the community gains access, it's helpful to know. And also, do you serve youth?
So I'm going to echo a lot of what my other panelists have said. We're looking for as much truthful information so we're not escalating an already tenuous situation. The demographics and all that stuff, currently it's being collected by the dispatch center. When we get on scene, we ask community members and PD and or case managers that are on scene. We do see a fair bit of those, school counselors, things like that, to just give us exactly what's happening. If they have, we get a lot of, with children, we do work a lot with children, particularly in South County. They really love to make their feelings known online through friends. So we often ask to see that, what the TikTok video was or what the text message was or things like that, just to get a very clear representation of what's happening. We kind of, gather everybody's information before we make our disposition. And like Allison mentioned, we do make use of the 1424 quite regularly to kind of support our holds and provide the next system of care with as much information as possible. Does that answer all your questions?
Yes, it does.
Perfect.
So we got 15 minutes left. I got a couple questions from the chat that I think are super relevant to our ability to be able to use this. So I'm going to put them out and then like basically speak up if your answer is different from your colleagues to have spoken, because I think there is going to be some consistency across the board. One is around undocumented communities. Are there any ramifications for undocumented individuals to use any of your services? I know in various moments police might be involved. Is there kind of any agreement that the documentation status is not part of this process? Kind of raise your literal or Zoom hand if you want to speak to this. Stephanie Lewis coming out from the backstage to give us an answer.
Go ahead, Stephanie.
Stephanie.
Sorry, everyone. I'm not supposed to be talking today, but in terms of our CAT team or any of our county operated teams, we do not have implications for people who are not documented. So we're there for a mental health call and we don't even ask those questions. So if you are dealing with a community member who's concerned, because a lot of times the person we're seeing may be documented, but there may be an undocumented person in the area or in the home, and police aren't interested in that at all.
Perfect. Really appreciate you. And I saw vigorous nodding by all of our colleagues, indicating a similar structure. Anyone else want to add to that? Go for it.
It's not a question we ask. It's not something we need to know or are required to know and would never ask. Again, sometimes there are tertiary parties that's impacted. it never comes up on our end, and we wouldn't have it come up.
Great, thanks everyone. There is another question about use of peers as part of the response. Do any of the teams have any peer professionals that are part of it? Go for it, Elliot.
So the macro team consists of 2 responders, EMT. They're supposed to take the lead on most of the medical issues. As you can imagine, I know Garcia can speak to this. People will walk into a CVS, be like, my knee hurts, and now an ambulance or a fire truck or something has to come. So we have an EMT to address some of those basic medical needs that we find in the street, offer a lot of wound care and guidance, and then they can do the upgrade to any further medical need, a BLS ambulance, ALS, or otherwise. The second member of this team is a community intervention specialist. This is a role that Oakland made. It is more akin to the peer role. We ask it to be individuals that have experience with the town, that have lived experience with either relatives or themselves, justice involved, unhoused, addiction, mental illness, what have you. And really, more importantly, a heart for service. And if they can bring all of that to the table, they make a perfect macro candidate. Again, it's a great opportunity to join the fire department in a capacity that many probably would not have had the opportunity before, to have a union job within the city of Oakland. So we really think that we've found a great way to integrate these individuals into the department without making them feel lesser than. The roles are the same, they get paid the same, they work together. And I can tell you, the vast majority of our calls, I think, in the month of August, 98% of our calls did not require the medical need. So the medical person's great. It's a great opening. Hey, let me check you out, make sure you're good to go. But having to upgrade to that higher level of medical care is very rare. So it anchors us to the department, but so much can be done by caring, compassionate folks that show up and put themselves out there and try to make a connection.
Thank you. Does anyone have a response that is?
I do.
Yeah, please.
So from the county teams here, so part of our outreach and engagement teams have peers, and so the mobile crisis teams and outreach and engagement teams collaborate pretty closely, and so occasionally a peer may be on scene as well, if they're already receiving services from our system of care, trying to link them to support. And so in that sense, we do have peers on our teams. And then also to your point, Elliot, around like medical care. And so our 2 outreach and engagement teams that I did mention, because we were focused on crisis, they do follow up after we've responded to crisis. One is the geriatric assessment and response team, GART, and the other is Crisis Connect. And those teams also can be referred to directly. But to your point, Elliot, we have a nurse on the GART team, and folks will be like ready to go to get their vitals read and all those kinds of things. And it kind of opens a door to, further conversations. And so just acknowledging that piece, and then also to be able to have people who have lived experience also is meaningful for the clients as well, because of, just being understood. So that is all I will add.
Thank you. That's helpful. Go for it.
I'll just add, so our model is a little different. We're staffed with 1 firefighter paramedic, 1 firefighter EMT. And that is because of the nature of the calls that come in. Sometimes you get on scene and it's like, well, this isn't really a mental health crisis, but they could be having some sort of a medical emergency. So we have the ability, we carry ALS equipment with an EKG monitor so that we can, take their 12 leads, stuff like that. They also have the capability to drive them to a facility if they need to. We don't have to call an ambulance or engine to come down and do that. As far as peers go, what I think one of the unique situations for us is because of the line of work that we're in, we get a lot of experience on a day-to-day basis, engaging with all different types of members of the community. And you can see that when the care team members, and I'm sure Karen can attest to this, is the care team members are very good at taking that experience that they have. It's kind of like a, life experience type of thing. And they can use that in the conversations that they're having with clients to initiate those conversations and kind of get them kind of to figure out like what direction we need to go, what services can AFS put them in touch with. So while we don't have actual peers on the team, it's just kind of something that we just pick up through our line of work anyways. So
That's really helpful. Thank you. The next question, with 8 minutes left, but it feels really important because it could be a deterrent, and we hear this concern on the crisis line, is about money. So could the interaction with you all result in someone getting a bill in the mail? Like how does the cost structure work? Might you
Wait, we
call
can bill
somebody?
people? Is this an option? Is this really an option? I mean, I'd love to send a bill. Don't know who we could bill. No, our services are right now, they're available for the community. And, you know,
Yeah.
I don't know. I guess it had to be like a mutual aid thing for me to be able to bill. I think we want to add a clinician onto the macro staff that can help with some billing back. We don't have that right now. So it may be something in the future, but
Yeah.
I know sustainability is going to be on top of mind for all of us, especially the next few budget cycles. So, yeah, it's something that I think we're going to be focused to think about more 2025, 2026. But
Yeah.
I
I think when people are worried about it, they're picturing, like when an ambulance shows up, like think like traditionally.
Oh,
You're
yeah.
having a hard time, like you fall at Safeway and you're like, I'm fine, I'm fine. They're like, no, we got to call an ambulance. An ambulance shows up, you ride in the ambulance. Then like a month later, there's a bill. For many people, there is a bill. And we hear folks on the crisis line, and there's been a number of people who put it in the chat of, is cost the barrier? So I wanted people to hear from you all, of
Yeah.
course, directly, that the mobile crisis services that we're discussing today, they are funded by the governmental entities that are in charge of that area, be it countywide or citywide teams. These services are public services. Yeah. We wanted people to feel good about that. And the last thing is there any misconceptions that you find yourself having to constantly address about your services? So with 5 minutes left, I think that's a good way to wrap it up, is to allow you to give us, if you have something that you want to address, give us a little nugget to take away of what's a misconception about your service. Clara, go for it. Your smile tells me you have one.
We actually discussed this as a team as if we were going through the questions. Our biggest misconception when we get on scene, both by police officers and community members, is that we can just take people away without doing an assessment. They are, either, Elliot, like I said, they're lying on the floor minding their own business, or they're just really upset or responding to internal stimuli. They're clearly not okay. You need to take them somewhere. And we do a lot of education around that, and the fact that we cannot remove somebody's rights just because you say so, unless there is a risk. So I think that is the biggest misconception about what we do.
So, who would like to go next?
I'll piggyback on Claire's piece. We can't remove people. It's nothing is forced. It's all voluntary. I'd love to reiterate that. We are not enforcement. We don't write tickets. We don't do anything of that nature. We can't arrest you. We don't want to be. I think those are the biggest misconceptions. We're not the police department. We're not violence prevention. While we work with a lot of homeless people, we're not homeless services. I would want everybody to know we're only 2.5 years old. So you got to give these things time to grow, flourish, and find their where they fit in the broader public safety landscape.
So appreciate that.
yeah, I think that's a big thing that I'm coming across, is the fact that it is such a new idea of a program. Like the Alameda Care Team is only 2.5 years old as well, and we're learning stuff every day. We're constantly looking to see ways we can improve our service delivery, how we can improve the experience for the client. We're actually in the process of doing like a SWOT analysis right now to see how we can change the training, the deployment model, staffing, and stuff like that. So I think that's one big thing out there, is like, there's, as far as I know, there's no two programs in the country that are exactly the same. So, and a majority of them started out as pilot programs. So we're all kind of trying to pave the way in a way, but at the same time, we have nothing to look back and say like, oh, let's model it after this. So, but it seems to be working. And then, while I do want to echo kind of the, it's not a homeless outreach team. However, we will respond to call. Our model is, if you call for someone on the sidewalk, we're going to send the care team out there to see what's going on. 9 times out of 10, it's kind of one of the, like, hey, I'm just taking a nap. Okay. People are going to keep calling. If you sleep here, do you want to move over here or there? We will still go out to those calls. However, that is not what the care team is for. And then Karen, I think, was going to speak a little bit more about the whole 5150, 5585 stuff, because that's also a common misconception.
Go for it, Karen.
Yes. As Clara had said, I think people expect us, like, it is really disturbing when family members have a loved one with a psychosis, or somebody is feeling down and suicidal, and there's an expectation like this person is struggling or has acute symptoms, you're going to take them to the hospital, and we really have to do a thorough assessment and make sure that we're matching legal definitions of criteria so that we're not taking people's liberties away. It doesn't mean that we're not caring or that we don't recognize this person is in distress or that the family isn't in distress. It's that we have to, be really close to the letter of the law for 5150 and 5585s. And so that's really difficult. I would say, since there are so many providers, sometimes it's been a challenge when a therapist, a clinician is saying, oh, they absolutely meet criteria, just, take them. And we of course will listen, but we have to start from fresh and do a very thorough assessment. And part of that assessment is, of course, listening to, like, what was the baseline? What changed? What are you seeing? What are your concerns? And the same with family members. But our assessment may not match, and that can be really frustrating to therapists. And again, it doesn't mean that we don't see that there's a problem, but it just means they're not matching at that moment. And so I think what we try to let people know is, like, we have a case management program. They're going to call you tomorrow. We will try to link you to ongoing services or reconnect you to services that can help, and have therapists that can support you as well to stabilize. But we're not going to be able to just take your word for it. Our assessment is showing this. And so I think those are the biggest things. The last thing is, like, our case management portion. I think families or individuals are told that we'll do follow-up case management. And so when we call, they'll say, oh, I heard you can get us housing today, or you can, help with some major problem that we're all struggling with, helping clinicians, getting our clients connected to. So I think they're expecting that we're going to solve the problem the next day. And it's really a long process. We're going to be along with you on the journey. We're going to utilize all of our resources, but there's no quick fixes for some of these social service deficits and needs.
Totally. Allison or Tama, any final words before we say goodbye? Okay, it's okay if not.
Just gonna echo everyone else. Yeah,
cool.
I mean, I think that is
pressure. And for the helpers in the room, I always encourage us to check in with ourselves of, when is it that our own kind of becoming hopeless or our own desperation to help our clients is kind of clouding our judgment in terms of how we're collaborating with our other colleagues in crisis services. Tama, sorry, I accidentally interrupted you.
No, I would just echo what everybody else has said, and also just invite folks to call when they need to consult to try to, like, work through some of these issues, right? Like the things that come up when trying to make decisions, or even to be able to get the help. Don't feel discouraged about not knowing everything up front at the time that you're making your own considerations from what you're being exposed to, and to give us a call so we can work together to problem solve.
Yeah, you all are getting so much love in the chat. Thank you for your work. It's not easy work, but we really need it in order for our communities to feel supported. Your work is so important. And I ran this exact same panel, not the same individuals, but the same programs 2 years ago. And so much has shifted. That was 2 Septembers ago, and so much has shifted. The capacities have increased across the board. There's new teams on board. So I think as a community, as a county, we are constantly working to meet the unmet needs of individuals in crisis. So thanks everyone for your partnership, and hope you have a good rest of your Friday. Take care, everyone.